Yes, sir, we are live now.
Okay, Jyotsna, you can start.
Good morning, Gansham sir and Srinivas sir, and good morning, everyone. Today we'll be just going through EEG interpretation for intensivist. EEG is actually a electrophysiological technique for recording electrical activity from cortex that is predominantly from the cerebral convexities. The action potentials cause depolarization of presynaptic nerve endings, which release the neurotransmitters at the synapse. These neurotransmitters may be excitatory or inhibitory postsynaptic potentials. And to record an electrical activity, at least an area of 6 centimeters of brain is required to produce signals on the EEG. This electrical activity is generated in the cortex, but its rhythmicity is regulated by the thalamus. Thalamus actually functions as pacemaker for certain cortical rhythms like alpha activity and sleep bundles. Thalamic and cortical neurons interact through feedback mechanism. Like example, during activation, there is an eye opening or anything. Input from the reticular activity inhibits the rhythmic discharges from the thalamus, which produces desynchronized synaptic potentials, that is alternating that is attenuation of the EEG activity. So they work in a feedback mechanism, and the electrical activity does not project in a focused manner. It spreads out as it traverses the brain and also the skull. So usually we need a large potential, will have more large potential, will have widespread field on the EEG, which will involve many electrolytes. So a prominent waveform on EEG, which is confined to one electrode, is usually taken as an artifact unless it is proven. Coming to artifacts, there are many features of EEG that are suggestive of artifacts. Example like activity or waveform that is confined to a single channel, or atypical generalized waveform potential, or highly stereotypic and monomorphic pattern, which has very low activity or a very high frequency, which is distributed over multiple electrolytes, but there is no specific physiological field according to the distribution, and it also can be a periodic pattern with a perfect regularity. Coming to the types of artifacts, and commonly what we see in the ICU, usually they are like instrument non-physiological artifacts, like instrumental artifacts, electrostatic, magnetic, and all. Electrode artifacts can also be seen, lead movements, photic cell artifacts. Environmental artifacts are important in our ICUs, where there are ventilator alarms, intravenous drip artifacts, CRRT artifacts, if there is any percussions from the bed, if the patient is on ECMO. And there are also physiological artifacts, like if the patient has spontaneous eye movements, ECG, pulse artifacts, pacemaker artifacts, etc. And there can also be a component called glossokinetic artifact, where tongue movements can also like influence the EEG activity. Coming to EEG machine as such, it records the electrical activity which is generated by the cerebral neurons, like in the form of the potential difference between the electrodes that we choose to place. And once this is taken, these EEG waveforms are digitized and amplified. Later, there are filters that remove the noise. It could be a high frequency filter, low frequency filter, or just the notch filter or the noise filter. And this is displayed as waveform, which is different in morphology and also the frequencies. Coming to EEG placement, there is a standard recording placement of the leads, which we typically use, that is 21 electrodes, which are applied according to the international 10 to 20 classification system. This we designate according to the areas, like leads are placed over the frontal area when they are given as F, temporal area T, central area C, parietal as P, and occipital as O regions. Even numbered electrodes are to the right side of the right hemisphere, and odd ones are to the left. Whenever there is a postfix Z, that refers that lead is in the midline. And usually any EEG recording, the standard time is 20 to 30 minutes. This is pictorial diagram just showing 10 to 20 system of the electrode placement. Electrodes are placed like 10% or 20% from distance from nasion to inion in the sagittal lines. And there are many types of EEG machines like routine EEG, which is huger one, ambulatory EEG, EEG which gives us the video recording, EEG that can be done in sleep, and we also have amplitude integrated EEGs and helmet EEGs, which most of the neuro ICUs use, and we also have continuous EEG monitorings in the ICUs. Coming to basic EEG waveforms, there are mainly five waveforms which we see. They are gamma, beta, alpha, theta, and delta. Gamma frequency is greater than 30 Hz, beta is 13 to 30, alpha is 8 to 13, theta is 4 to 8, and delta is less than 4. This is just a normal adult EEG, which is demonstrating the alpha activity in the box that is highlighted. This alpha activity is usually evident over the posterior cortical region, that is reactive region, which gets stimulated to arousal. So, this leads to attenuates like graph is attenuated on eye opening or any other activity. Beta activity is present over the anterior regions. Coming to effect of the drugs on EEG, beta activity is initially increased by most of the sedatives, anesthetics, and anticonvulsant medication. And when we start giving any drug or increasing the depth of anesthesia, there is lowering of the frequencies. Coming to epileptiform activity as such, it can be assessed in the presence of pharmacological sedation also. Temporary weaning of such agents will produce more reliable EEG for interpretation and also the background activity. In encephalopathy or global cerebral dysfunction, this is common complication which we encounter in critically ill, and we have wide range of etiologies like metabolic derangement, hepatic renal failure, systemic infections, toxins, traumatic, and hypoxic ischemic encephalopathy also. Though EEG is generally not specific to the etiology, but it is very sensitive measure of cerebral dysfunction, and it also gives us the information regarding the severity of encephalopathy. The earliest changes of encephalopathy are usually slowing or losing the alpha rhythm. Coming to the most frequently encountered activities in the critical care, mainly 7 activities are there, which is a slow wave activity, frontal intermittent rhythmic delta activity, triphasic waveforms, epileptoform patterns, periodic discharges, which are again subdivided into 4, suppression, and the burst suppression. Coming to slow wave activity, these are theta and delta frequency activities. And to say that this is a pathological form of slow wave activity, more than 50% of the complete EEG should have this activity. Usually, this is neuropsychiatric drugs are commonly associated with this type of slow wave activity. Examples are like tricyclic antidepressants, lithium, and clozapine. And asymmetrical slow wave activity is also a is seen in structural cerebral abnormalities like tumor, gliolysis, encephalitis, and CVAs, subarachnoid hemorrhage also. Coming to this frontal intermittent rhythmic delta activity, this is actually a regular and it is like sinusoidal or sawtooth waves which occur as intermittent bursts, and they are also synchronous over the frontal regions. But occasionally they may be unilateral also, but usually they are bilateral only. This is commonly associated with mild to moderate encephalopathy in responsive patients with metabolic derangement and cerebrovascular disease. This is just a pictorial representation of this frontal intermittent rhythmic activity. This is non-specific, but it can also arise due to structural or non-structural pathologies. Coming to triphasic waves, they arise as a result of toxic, metabolic, and hypoxic encephalopathies and is also commonly seen in prion disease. These can occur in overdose of several drugs like sodium valproate, overdose of the drugs like sodium valproate, baclofen, lithium, levodopa, barbiturates, and also serotonin drugs. Here we can see the upward, initially a sharp transientness, downward deflection, and also the upward deflection. That is, initially there is a positive wave, then a negative wave, and which is again followed by an upward deflection. Coming to periodic discharges. Periodic discharges are like repeating waveforms of uniform morphology, duration, and in the discharge interval is also is there, but they usually follow majority of the EEG recording. Usually, these discharges are again classified into four types based on their topography and the interdischarge interval. So they are like lateralized periodic discharges, bilateral independent periodic discharges, generalized periodic discharges, and stimulus induced rhythmic periodic or ictal discharges. Coming to lateralized periodic discharges, they are actually seen in acute destructive lesions like CVA, space occupying lesions, encephalitis, and also herpes simplex encephalitis. It also suggests that 90% of these patients will experience seizures during the course of their illness. Coming to this bilateral independent periodic discharges, this is like presence of lateralized discharges in both the hemispheres, and usually they are asynchronous. And the common pathologies of these BIPDs are hypoxic ischemic encephalopathy, severe hypoglycemia, CNS infection. They are most frequently associated with seizures, and they are associated with poor neurological outcomes for the patients. Coming to generalized periodic discharges, these are commonly seen in toxic encephalopathy, metabolic encephalopathy, hypoxic encephalopathy, but they can also occur in non-convulsive seizures and non-convulsive status epilepticus also. Discrimination between these conditions is like difficult, but we have to interpret according to the clinical condition of the patient, and the management of this is like treatment of the underlying cause, and prognosis should be guided either by the response or reversibility of the cause, but usually the prognosis is poor. This is just an image showing the generalized periodic discharges. They are usually synchronous, periodic, and they occupy more than 50% of the recording. Coming to stimulus-induced rhythmic periodic or ictal discharges, they are commonly seen in comatose patients. So the significance of all these periodic discharges should always be interpreted in a clinical context, but it's like they are more frequently associated with seizure, and prophylactic anticonvulsant may be necessary. Like example, if a patient is presenting with fever, delirium, and EEG is showing lateral periodic discharges over the left hemisphere, the usually looking into fever and all that, we usually take it as a herpes simplex encephalitis. And if the patient has the same things on right sided hemiparesis, usually it is because of the hemispheric dysfunction, which could be secondary to a stroke. Coming to suppression, suppression is like low amplitude recording where the voltage is less than 10 millivolts, and it is uniform, like it is in the all channels, and it can also occur as a result of deeper states of anesthesia, which is reversible. But in pathological states, suppression is suggestive of gross cerebral distribution, and it also indicates a poor prognosis. This is also not etiologic specific, but we have to look again into the clinical context, and it may also be because of the cerebral intoxication, post-ictal suppression, brainstem hemorrhage, cerebral ischemia, and also in cases of edema. Electrocerebral inactivity is something where suppression is there by global laws of electrical activity, but here the voltage is less than 2 milliequivalents. Profound hypothermia and severe hypotension may also lead to this. Like those condition also we see suppressions. CNS depression to intoxication are potentially reversible causes of this electrocerebral inactivity, but we have to exclude them before we are labeling it as irreversible coma. These both are showing, one is showing the suppression activity and one is the diffuse slow activity. Coming to burst suppression, as the EEG becomes discontinuous, there are bursts of sharp and slow wave activity, which are variable in duration, which will be alternating, and they will also have variable periods of attenuation or suppression, and the voltage is usually below the 10 millivolts. And for defining it as burst suppression, usually it should be more than 50% of the record. And an alternative definition, sometimes we use clinically, describes burst suppression as state of unconsciousness and profound brain inactivation in which EEG shows periods of electrical activity alternating with periods of isoelectricity or electrical silence. And the common causes of this burst suppression are sedatives and general anesthetic agents, status epilepticus, and HIA. And consideration of trial period of sedation hold unless being when we are using it for therapeutic purposes, better is give a trial period of hold and get this done, because this may be associated with myoclonic status epilepticus also when there is a hypoxic insult, and this carries a very grave prognosis. Coming to EEG in epileptiform disorders, non-convulsive seizures and status epilepticus should be considered in patients with disordered consciousness, particularly those in coma with history of epilepsy or like stroke, cerebral infection, or post-neurosurgery. We should all be vigilant for the possibility of ongoing subclinical seizures also after convulsive status epilepticus have terminated, and also when the patient is in HIE setting. To confirm the diagnosis of NCS or NCSC, this repeated activity of this epileptiform discharges should be at a frequency of greater than 2.5 hertz. But we diagnose as non-convulsive seizure if it persists for 10 seconds, and we diagnose as non-convulsive status epilepticus if it is for a duration of 30 minutes. And EEG for prognostication in coma. Coma, we know, like is defined as eyes closed state of unresponsiveness with severely impaired arousal and cognition. In comatose patients, EEG can be used for evidence of potentially reversible causes, such as intoxication with sedatives, non-convulsive seizures, or non-convulsive status epilepticus. It also helps us in neuroprognostication, and it also helps us in assessing after the cardiorespiratory arrest or traumatic brain injury. Favorable outcomes are seen when there is rhythmic EEG activities, and whenever there is any alerting stimuli, when the EEG is reactive, that is favorable outcome. Reactivity is something like reproducible EEG is there whenever there is response to, when patient is becoming alert or when we give a noxious stimuli like pain or anything. And this should be carried in terms of amplitude, frequency, or both. And sometimes they may not be we may not be able to quantify it on the EEG. Unfavorable outcomes are seen in patients where there are non-reactive, discontinuous, or suppressed EEGs with presence of epileptiform discharges, generalized periodic discharges, or both of them. Coming to EEG in ICU, critically ill patients are predisposed to conditions like cerebral ischemia, hypoxia, cerebral edema, and also raised ICP. So, early detection of all these and management will usually decrease secondary brain injury, and it also improves the neurological outcome. The concept of continuous critical care EEG has been used nowadays in all the neuro ICUs and ICUs, and this also can be used as ancillary test to support diagnosis of brain death. Coming to critical care continuous EEG or CCEEG, it is used in patients who are predisposed to secondary, whom we think that there may be chances of secondary brain injury, and if the patient has neurological deterioration. This American Clinical Neurophysiology Society now recommends critical care continuous EEG for identification of cases of non-convulsive seizures and non-convulsive status epilepticus, and we also are supposed to use this in monitoring response to the drug therapy which we are using, like anticonvulsive therapy in all these conditions, and also to modify the drug therapy. And it also helps us in predicting the outcome of patients with severe encephalopathy. Coming to the indications of critical care continuous EEG, the indications are altered mental status with previous history of epilepsy, unexplained altered mental status, fluctuating level of consciousness, acute brain injury due to any cause, a person who has had a recent convulsive status epilepticus now coming to ICU again with some other complaints or seizures again, and any patient who has stereotypical activities like nystagmus, face and limb myoclonus, autonomic instability, and also episodic posturing. uh, uh, Continuous critical care ECG for non-convulsive state seizures and status epilepticus. Usually, there is no consensus about the duration of monitoring, like how much time we have to do and all. But there have been studies like Mayo Clinic study. They have done 30-minute EEG was done. A South Indian study which was conducted by Dr. Radhakrishna, which shows like emergency 60-minute EEG was enough. And there is one more study, which Clausen study. There, half of the patients were diagnosed within an hour. They have started using this continuous critical care EEG monitoring. And for doing this CCEEG for non-convulsive status epilepticus, we use Salzburg criteria. Coma and presence of periodic discharges are also in EEG predicted delayed occurrence of first seizures. And these two observations indicate that, depending on all these studies and observations, usually they indicate that 24 hours of continuous EEG monitoring should be sufficient to exclude non-convulsive seizures or non-convulsive status epilepticus. Coming to the Salzburg consensus criteria for using in non-convulsive status epilepticus is, here we may have two types of patients, like patients without known epileptic encephalopathy and patients with known epileptic encephalopathy. In patients with without known epileptic encephalopathy, epileptic discharges greater than 2.5 hertz, or epileptic discharges with less than 2.5 hertz, or who have rhythmic delta or theta activity along with EEG and clinical improvement after initiation of our AED drugs, and subtle clinical ictal phenomena or typical spatiotemporal evaluation. Coming to patients who are known who are known cases of epileptic encephalopathy, increase in prominence or frequency is enough, like which is compared to their baseline, with observable change in clinical criteria, and improvement of clinical and EEG features with the IV AEDs which we have started. So this is the Salzburg EEG consensus criteria which we use. Coming to like the one more indication for using this continuous EEG in our critical care ICUs is for assessment of treatment efficacy for seizures and status epilepticus. ACNS again recommends to assess the efficacy of continuous IV drug therapy with regard to seizure suppression, burst suppression, or complete suppression. It is mandatory in management of refractory status epilepticus, while maintaining a burst duration or suppression duration ratio of about 1 is to 4. It is also recommended that this ratio is recommended, or suppression duration of 10 seconds followed by each burst of activity is recommended. And weaning of anesthetic agents is usually done after patient has been in burst suppression for usually 12 to 48 hours. And frequently reviewing during this phase is important so that the patient does not land up in breakthrough seizures. Usually, breakthrough seizures occur. Restart burst suppression and continuous EEG can be monitored if patient has big breakthrough seizures. And one more indication for using this continuous EEG was for assessment of severity of encephalopathy. Most of our patients have altered mental status due to sepsis, HIE, or some or the other metabolic derangement. Most, like 88% of encephalopathy patients in MICU may have non-convulsive status epilepticus. Patients with sepsis also have higher rate of this, and periodic discharges are also more with than those without sepsis. When we compare patients with sepsis and without sepsis, usually sepsis patients may have more predominance of these kind of periodic discharges. And the EEG patterns that have unfavorable prognosis are alpha coma, burst suppression pattern, periodic pattern, and electrographic seizures. And the EEG patterns that are associated with the favorable outcomes include any seizure activity that has background continuity, spontaneous variability, reactivity to the stimulus, and is also presence of normal sleep pattern. Coming to grading of coma according to EEG, we have five grades: grade 1, 2, 3, 4, and 5. In grade 1, like mild degree encephalopathy, predominantly the posterior dominant rhythm is the alpha range, and reactive intermittent theta activity can be seen. In grade 2, this posterior dominant rhythm is predominantly theta activity and is often reactive, and it may also be associated with alpha or intermittent delta activity. Coming to grade 3, which is moderate to severe, there is background of delta activity and spindle coma. Coming to grade 4, there is burst suppression or alpha coma, beta coma, theta coma, or diffuse attenuation. That is, whole EEG has less frequency, like less than 20 microvolts. Coming to grade 5, which is electrocerebral inactivity, we just see the suppression, like ECI is present in the EEG. Coming to EEG in suspected brain death, essential findings to diagnose any case of brain death are coma, absence of brainstem reflexes, and apnea. But EEG can be used as ancillary test to assess brainstem death when underlying medical condition prevents us to complete the clinical examination or apnea testing, or neurological examination and apnea test findings are equivocal, and when there is suspicion of superadded medication and hypothermia effects also. And it also helps us to minimize the inter-examination observation period so that organ donation procedure can be initiated quickly without delay. Coming to the trials, we have an CERTA trial which was done, which showed like difference between continuous versus routine EEGs. Here, the group of patients who were analyzed were patients after the cardiac arrest. Here, two types, they were randomized into two groups where one set of patients were undergoing this EEG, like continuous EEG was done for 30 to 48 hours, and the other set had only two times EEG was repeated with 20 to 30 minutes interval each. Like whenever EEG was done, it was done between 20 to 30 minutes. And they actually analyzed, and they like compared the outcomes, and they concluded that there is no much like there was comparable outcomes in both comatose patients after the cardiac arrest, but seizures and anti-seizure modification were more frequent in those patients undergoing continuous monitoring. Coming to decision regarding prophylactic AEDs in stroke, we can take the help of two help as 2B criteria, because this is a clinical prediction tool that helps us if we can go for, like based on continuous EEG, we can go for whether this person requires prophylactically any anti-epileptic drug or not. Initially, continuous EEG is done for greater than 1 hour, and we go with counting the points. If the score is 1, it is recommended to continue EEG for 12 hours, and if the score is greater than 2, we have to continue EEG for the next 24 hours. Coming to few more trials which have been studied in the recent, like 24 and 25. This is one more study which is showing us like continuous electroencephalogram monitoring in the ICU. This was a prospective study which included adult patients. This study was done in one ICU, and here the severity of the patients were taken according to Apache 2 and SOFA scores. All the comorbidities and the reasons for undertaking EEG patterns and the strategies were used. Continuous EEG patterns were correlated with patients' outcome. And they concluded that the management of critically ill patients is influenced by continuous monitoring of EEG, which could modify the therapeutic strategies, and it also appears to be a useful prognostic tool in critical care patients. Coming to one more study which tells us that if electroencephalogram unit, this improves the outcome in status epilepticus patients. This is like a retrospective study which they have done the study before and also after the patient has been discharged. Here continuous EEG was recommended for status epilepticus for management, and also as long as patient was in the ICU. Here, they also concluded that integrating neurology expertise in ICU through establishment of this continuous EEG unit with nearly real-time review, this shortened the status epilepticus duration, increased likelihood of returning to premorbid neurological function with increased number of anti-seizure medication that they have used. uh, Coming to a study which is showing like who will really benefit from this continuous critical care EEG monitoring. Here, this study, they found out that all this was depending on the ICUs, like high resourced ICU, moderate resourced ICU, and limited resourced ICU. Usually, critical care like continuous EEG monitoring is mandatory for super refractory status epilepticus, acute brain injury with encephalopathy, systemic encephalopathy, post cardiac encephalopathy. But in limited settings, they were using it for a lesser diagnostic things. And in high resource, they were able to use even for the small, for the initial 24 hours also they were doing. So the priority of continuous EEG monitoring was highlighted in this trial. And this was also a trial where they have included like convolutional neural network, which is an advanced version of artificial neural network, was incorporated into this study. And then it was decided that this model also provides an efficient and accurate tool for detecting seizures and other clinical ICU or EEG patterns. And this will also decrease the burden of the physiologist and the intensivist also, like where we go sit and do EEG on a timely basis. But if continuous EEG is there, that could give us more benefits. Coming to take home messages, EEG is a real time objective measure of cerebral activity, which is available to clinicians in the ICU, particularly where clinical neurological examination is difficult or unreliable. It can indicate cortical, subcortical, or arousable disturbance, and it also helps us in identifying the epileptiform activity, which helps us in diagnosing and also managing cases of epilepsy. It is complementary to neuroimaging, and it can also be used in conjunction with other neuropsychological techniques such as SSEPs in neuroprognostications for patients in coma. And continuous critical care EEG should be considered in all the patients with acute brain injury, irrespective of the cause, as it monitors the underlying things. And it is recommended in patients with unexplained encephalopathy to detect non-convulsive seizures and non-convulsive status epilepticus. It also helps us in initiating the therapy, modifying the therapy, and also predicting the outcome of therapy. This can also be used as one of the ancillary tests for declaration of brain death, and it is used in sometimes for confirmatory study also. Electrocerebral inactivity implies that there is complete lack of electrical activity that is getting recorded in the brain. So, in patients with true electrocerebral inactivity, especially when it is present in 2 EEG recording at an interval of 24 hours more, neurological recovery is very poor or very less. My references were the article which is in BJA, which shows like Introduction to Interpretation of EEG in ICU, and also a textbook of EEG in clinical practice. Thank you. Thank you, sir, for the opportunity.
Thank you, Jyotna. I think the role of EEG has expanded in the recent times. The frequency with which we are doing EEG in the ICUs has gone up significantly. Hello.
Hello. Sir, you were not audible, sir.
So none of you didn't hear anything that I said.
Yes, sir.
Okay. See, EEG interpretation for the ICU or intensivist, no, there's a greater role because of the increasing incidences of disorders of unconsciousness. A good number of these patients may have non-convulsive status epilepticus or severe metabolic abnormalities, which can be diagnosed if you know how to interpret an ECG. And many times, because the ECGs are kept continuously, interpreting them and reading them at odd hours, you may not have a neurologist always available. So, as intensive care specialists, we should be knowing how to interpret an EEG and how to use it at the bedside. Thank you very much, Jyotsna.
Thank you,
We'll
sir.
meet again next week.
Thank you, sir.
Okay.